I want to thank Dahshu for providing the IDSWG the Zoom video conferencing services for this seminar. Also, I want to remind you that our KOL lectures are recorded. As a matter of logistics during the presentation, I will mute all other audio lines until the end of the presentation, when you will be able to unmute your line to ask questions, at which time we hope to have about 10 to 15 minutes for a Q&A session. So without further delay, Kong, the floor is now yours.
Thank you, John, for a nice introduction. And I'd like to also thank Dahshu for providing me with this opportunity. This is primarily based on joint research with Mo Huang, who is now at Pfizer, and Xue Zhang at University of Victoria in Canada. During the preparation of this presentation, we received numerous valuable comments from various Merck colleagues and other research collaborators. So this is the outline of my presentation. I will talk about two-stage adaptive phase 2/3 oncology designs with dose selection. There are two major considerations for such designs. One is the probability will pick the winner. Here, winner refers to winning dose, the dose with numerically better survival under null hypothesis, are called W. And the second consideration is the consistency between the two stages, I call it C. W is the primary focus of my presentation, although I will also talk about the importance of C, which actually makes us rethink about the difference between inferential versus operational design, and broadens our scope of understanding of the adaptive design. And further, it also has to do with some practical considerations. And speaking of practical considerations, I will illustrate how this new design concept applies in practice. So this is a brief introduction. As we know that adaptive phase 2/3 design with dose selection can not only meet the FDA's Project Optimus requirement of dose optimization, but also it can reduce the sponsor's risk of selecting a suboptimal dose. And to me, it holds great promise in contemporary oncology drug development. Alternative approach is to conduct dose ranging study without including a control arm, and then select dose and then proceed to phase 3, which, as we all know, may not be as fast as adaptive design approach. Of course, the traditional approach of carrying a dose as identified from dose selection and to phase 3 is now less acceptable to regulatory agencies. Dose optimization is arguably one of the most important issues in oncology, there are a lot of rooms for playing in this space, of course. So my focus again is just in the limited scope of adaptive phase 2/3 design, which otherwise is critical to the development, of course. And the conventional approaches to multiplicity adjustment for such designs are based on the very conservative assumption that that's not aligned with reality. Today, I will try to challenge the status quo to advance the biostatistical science, so that the full potential Project Optimus can be unleashed. So let's start with ideal adaptive phase 2/3 design. It consists of 2 stages. In stage 1, it has dose 1, dose 2, and control. Once you select those, you carry it to phase 3, which is stage 2. Ideally, the dose selection and the final analysis of the data are based on the same endpoint. And the same endpoint can be observed immediately, so that the dose with a superior efficacy at the time of dose selection is carried forward to stage 2 with certainty. This is actually a fundamental assumption under the conventional p-value combination tests. When you combine the two p-values from two stages, you divide the p-value from stage 1 by 2, which essentially assumes that you have chosen a winner with absolute certainty. That's why you take this Bonferroni type of penalty. Of course, there are some minor modifications, minor version differences if you depend on which version or the p-value combination test you use. And the second issue related to adaptive design is consistency in terms of stage 1 and stage 2 conduct and data, which is often a review issue. It has never been, to my best knowledge, explicitly incorporated into the conventional approaches for multiplicity adjustment. Now let's talk about the probability of pick the winner under the null hypothesis. The chosen doses for this study are often under assumption that there are likely to be, there is no clear winner, at least as a prior assumption. So when you also add to the fact that dose selection during the study is imperfect, because now oftentimes the primary endpoint, like usually overall survival, cannot be observed immediately. So throughout my presentation, I will assume that the overall survival is the primary endpoint of the phase 3 study. And due to the incomplete follow-up, it's problematic even when the primary endpoint is used for dose selection, because the short-term follow-up may not give you the unbiased treatment effect. And early efficacy endpoints often have uncertain correlations with primary endpoint, especially in settings that patients' survival is long. And now when safety and tolerability are prioritized over efficacy under the Project Optimus, it becomes even less clear whether the selected dose is better in the primary endpoint. Granted, when you try to select a lower dose, which comes with better safety and tolerability, patients' quality of life may be improved, but whether their survival is going to be improved is even less clear. The true probability of pick the winner can range now from 0 to 1 in this imperfect setting, which is a reality. And we should be concerned about not only random high, but also random low. Random high, the concern about random high is the reason why we do the multiplicity adjustment. But now we should be also concerned about random low. The last thing a sponsor wants is to pay the penalty for random high by taking, for example, the conventional p-value combination test, but when the actual outcome is a random low, which potentially leads to an underestimation of treatment effect. Now let's talk about estimation of W. W can be estimated when the decision criteria are pre-specified and binding. You can take a look at the reference number 2 in the slide deck, which I'm sure assume that everybody has received. However, I did modify a little bit, so this slide actually was not included in the slide deck that was circulated previously. But if you want me to send you the updated slide deck, just send me an email. And if the OS effect is constant over time, OS would be the best endpoint for dose selection. In practice, it is usually arguable whether it's constant over time. That's why we try to use early efficacy data or even safety data to kind of to gauge whether which one might give us the better OS in the end. Nevertheless, the OS information can, in terms of its information fraction, not the actual outcome, can be the basis for a conservative estimate of W by treating as if OS were used for dose selection under this ideal assumption that the treatment effect is constant over time. Symbolically, W would be equal to the probability of Y greater than 0. Y here refers to the treatment difference between the two doses at the end of the study. Given that there is a difference at the dose selection based on X, and you do some quick calculation, it's just 2 times the joint probability of X and Y, and X and Y are correlated. And in reality, again, the correlation can be negative or positive. When the information fraction of OS for the select dose versus control is 25% at the dose selection compared to the final analysis for stage 1 patients, this is just a hypothetical example, of course, the correlation between X and Y would be a square root of information fraction, which is equal to 0.5. And if you do a quick calculation, given that the X and Y are all standardized normal variables, the W would be 0.66. So it's not going to be 1. Now let's talk about consistency between 2 stages. In addition to the pure randomness, various other factors may lead to numerical inconsistency, which can raise the concern from regulatory end. For example, the trial begins with a limited number of sites in a few countries, which may not be representative of all sites used once the recruitment is fully underway. And the expansion from phase 2 to phase 3 may be perceived as a positive signal, attracting patients with poor prognosis. The consequence is unpredictable. And the sponsor may learn from stage 1 patients on how to manage AEs. As a result, the stage 2 patients may benefit. And the consequence of whether stage 1 and stage 2 patients still have the same treatment effect becomes questionable. Last but not least, naturally, stage 1 patients and stage 2 patients will have different follow-up time. That has impact on treatment effect as well. For example, if the drug has a delayed effect, it may favor stage 1 patients because these patients have longer follow-up. However, a crossover effect may favor stage 2 patients because stage 1 patients are more vulnerable. The treatment effect is rather the treatment effect of stage 1 patients may be more vulnerable to a crossover effect because the longer they stay in the trial, the more likely they will have the placebo arm patients, the control arm patients may get the benefit of crossover drug. Further, and this is kind of related to W, imperfection in dose selection exacerbates the consistency issue, as a regression to the mean cannot legitimately go in either direction. So let me explain a little bit with this simple illustration. Let's assume that the 2 doses have identical treatment effect. That's kind of the underlying assumption whenever it comes down to hypoviral adjustment. Although this stage 1 overall and stage 2 have comparable effect, the 2 doses in stage 1 show a numerical difference in the end, with dose 1 being superior to those 2 due to randomness. So this all refers to a survival endpoint. It's just purely due to randomness that if stage 1, dose 1 patients somehow have longer survival than stage 2 patients purely due to randomness. Now, if you have a perfect dose selection, you would have selected dose 1, right or wrong. And as a result, you have this regression to the mean effect. That means that stage 2 effect will be less, and that's why you need to pay the penalty because you have cherry picked the random high. Now, if this W can change from 0 to 1, not just 1 anymore, you could have also picked those two due to random low. And as a result, your treatment effect from stage 1 may be less than stage 2. That's kind of the extra complexity in terms of the inconsistency between stage 1 and stage 2. So the fact that W changes can vary from 0 to 1 makes this both possibilities likely. Now let's just get back to the numerical inconsistency part by doing a simple calculation. For time being, forget about those selection. It's just the bone of traditional study, whereas you have stage 1 and stage 2. And stage 1 may very well be just a go no go decision that doesn't have anything to do with those selection. And in this hypothetical study, it has 10 events. It's powered for detecting hazard ratio of 0.75 at 2.5%. Observed hazard ratio of approximately 0.84 would constitute a positive outcome. And we assume that stage 1 patients contributes 30% of overall survival in the pooled analysis. And in T is equal to 0.3. So I will use T to represent the contribution of survival from stage 1 patients at final analysis, of course, not at the dose selection. So in the first row, stage 1 hazard ratio is 0.954, and stage 2 is 0.795. The log difference between the two is log negative 1.2. In this case, if you are sponsor, you would be a little concerned because stage 2 is based on more patients, and it's probably giving you a more unbiased treatment effect estimate. But the stage 1 it doesn't look as good. As a result, your treatment effect is kind of quote unquote diluted by stage 1 patients. And in the last row, it represents the opposite situation, whereas the treatment effect is to some extent driven by stage 1 patients. And in the two rows in the middle, it's probably just acceptable, but the top and the bottom may be the issues that a sponsor and a regulatory agency may be more concerned about, respectively. Well, the chance of observing absolute difference greater than log 1.1 is about 55, just purely due to randomness alone. And if you change the absolute difference cutoff to log 1.15, the probability changes to 40%. So this just illustrates that there is a appreciable probability that purely due to randomness that you may observe some numerical inconsistency. If you are not conducting adaptive phase 2/3 design, nobody is going to care because nobody's going to arbitrarily break your data into like two pieces. But if you are conducting adaptive phase 2/3 design, sponsors and regulators will pay attention. That's kind of a hidden issue for any adaptive phase 2/3 design. So the discussion about W and C leads to a natural data-driven hypothesis testing strategy. You include stage 1 patient data in the final analysis if the absolute difference or log hazard ratio between the two stages for the select dose versus control, of course, is less than C. Otherwise, you only include stage 2 data. This essentially results in the hybrid design. It becomes more inferential as C increases and it becomes more operational. Otherwise, the resulting design is driven by data. And this approach is intuitive for statisticians, for non-statisticians, and proactively address the consistency issue, mitigating both regulatory and sponsor risks upfront. The primary final analysis, with or without including stage 1 data, will be conducted at adjusted alpha level, I call it alpha star, to control the overall type 1 error rate at the target alpha level. The alpha level is 0.025 if you don't have any intra-analysis, but if you already have a spend like 0.2% in intra-analysis, then alpha would be 2.3%. And then you adjust your alpha star accordingly, just downwards, to control the type 1 error rate at the target level. And computations of alpha star are all exact. Closed form can be easily derived. So you can go to reference number 1 for the details. So this is just an illustration of alpha star, how it changes with W. I assume that T equals to 30%, and the target alpha is 2.5%. You only need to focus on the the black line and the blue line. So the black line corresponds to the inferentially adaptive phase 2-3 design. Basically, you take C to be infinity. So regardless, you will just combine the data. What tells you is that when W is equal to 0.5, in choose, you shouldn't pay any penalty because it's just flip coin toss. You're not cherry picking those with better efficacy. Yet in practice, under the status quo, we are paying a huge penalty by implicitly assuming that you have certainty to have picked a dose. And in this case, the resulting alpha star is 1.64%. So not many people tries to evaluate, but if you are applying traditional p-value combination test, you may realize that the penalty is huge on it's implicit out there. But if and alpha star decrease as W increases, of course, the more cherry picking you are, the more penalty it is, and it declines slower. There was a typo in my slide deck. In front of you, it says faster, but actually it declines slower when C is smaller. For example, when C is 1.1 versus 1.4 or 1.5 or infinity. And C has a modulating effect and doesn't go to that extreme as the inferentially adaptive design corresponding to C equal to infinity. 1.4 and 1.5 just for illustration purpose. In reality, that's probably too much. It's just illustrate just to show that the alpha star is not necessarily monotonic in C. And going back to the hypothetical example before, if at the dose selection, the stage 1 patients only have a 25% information fraction as compared to the final analysis, and as such, a conservative W would be at about 0.66, and in this case, you apply the traditional inferentially adaptive design. The alpha star, i.e., the p-value should be compared to, is at about 2.2%. Again, that contrasts very favorably to the 1.64% you otherwise are using. And the downside of not adjusting, of not having a consistency check under the traditional approach is that you may run into the risk of having a treatment effect that's lower in stage 1, so that your treatment effect, overall treatment effect, may be diluted. But by saying that, I'm not by any means suggesting that you always need to check for consistency. So that's a point that I'm going to make in this slide. So bottom line is that you need to be mindful of the implicit assumption of W when applying any multiplicity adjustment method. If overall survival for the unselected dose is reliable by design, and W will be known at the end of the study, and it should be treated accordingly. For example, if it turns out that you have chosen a dose that has numerically inferior OS as compared to the unselected dose, you shouldn't pay any penalty, and you can go to reference number 10. So in other words, really the conventional approach of blindedly penalizing yourself for absolute certainty of cherry picking is just way too conservative. And the study, the study example referenced in number 10 actually was accepted by FDA. Otherwise, you can set W at 0.5 when there is no evidence of cherry picking at all. And reference 8 discusses HPV vaccine phase 3 study, whereas FDA agreed that since they used the PD biomarker, immunogenicity PD biomarker for dose selection, and there is really no evidence that's correlated with efficacy. Further, the endpoint was binary, and the sponsors use the exact method, which is conservative in nature. As a result, no penalty was paid. And you can always conduct sensitivity analysis as needed. For example, W can be set at 0.66 if 25% information at dose selection. Consider to add consistency check for pooling if there is concern about random low. And especially when there is also concern that the treatment effect may be lower in stage 1 patients than in stage 2 patients. So it's more for protecting yourself from having a diluted treatment effect. In the business of oncology in particular, physicians pay so much attention to the numerical estimate. Despite the two drugs having approved may not have the same acceptance to physicians, and of course HTA assessment also pays a lot of attention to numerical estimate. So that's something you need to be mindful. And another thing about this consistency measure is that in case enrollment pause and partial unblinding for the dose selection make the pool analysis questionable to regulatory agency, you can specify consistency check to alleviate regulatory concerns. In practice, when it comes down to powering a study, you may want to take a slightly more conservative approach. For example, by assuming W equal to 0.66 or even 1. But then when you analyze data, you can specify a more scientific and objective analysis that corresponds to a more reasonable W. And to me, there's little to lose, but much to gain. You can agree to disagree with regulatory agencies, and just in case p-value is positive under your analysis, at least you have a fighting chance to persuade FDA or EMA to consider the drug for approval. Now, let me also make some comments on rank-based inverse normal combination test. Details can be found in reference number 12, and there's rumor that it's being accepted by regulatory agencies. The test goes as follows. It nominates early efficacy endpoint, they call it biomarker, and then find a rank order of the selected dose based on the outcome of early endpoint, then adjust the p-value from stage 1 according to the correlation of the early endpoint and OS, then combine the p-values from the two stages. So essentially, they are trying to address, basically incorporate in the correlation between early endpoint and OS into the consideration without blindly assuming that the dose is chosen with certainty for to have a superior OS. So it's kind of implicit out there. The nomination with the biomarker is kind of artificial to me. I'm sure the authors probably disagree, but that's fine. And the correlation between the biomarker and OS in the final analysis needs to be estimated for implementation, although there's nothing wrong with that. And personally, I would argue, we should always consider that in related statistical issues. However, a more natural choice for typical study may be OS at the dose selection. As a result, the correlation is determined by information fraction without any need for estimation, and this practice is kind of consistent with the group sequential design framework. But of course, there is a limitation as to whether this method can be applied to all cases. If the primary endpoint data at the dose selection is so limited, or to the extent that there's none, you cannot use this kind of approach, and you probably will have to consider alternative approaches. Lastly, I want to comment if indeed the use of a kind of a intermediate biomarker for multiplicity adjustment is accepted by a regulatory agency, it kind of suggests to me that the use of OS at dose selection, which is more natural early endpoint, may be also acceptable. And the framework of a hybrid design allows for a consistency check that's missing in a combination test. So the incorporation of C and W are very natural in hybrid, but it's not so for other methods. Well, this is just a high-level discussion point. Type 1 error inflation in the inferentially adaptive phase 2-3 design with dose selection is primarily driven by the probability of picking the winner and the null. The conventional approach is ultra-conservative, especially under Project Optimus, whereas efficacy, whereas tolerability and safety are often prioritized over efficacy. The hybrid design is more flexible than conventional adaptive design and is especially useful when upfront decision on inferential versus operational is challenging and time-consuming. And for those who are working in the industry setting, we all have similar experience, whereas whenever you have proposal inferential design, all sorts of issues come out, like how to make those selection, how to talk to FDA, etc. Just a lot of discussions, and so much so the planning of design itself can easily drag on and for quite some time. To me, an easy solution is to just study the study as a randomized controlled phase 2. You keep those selection insulated from the study team and make decision later, whether it's going to be operational, inferential, or hybrid. You can delay that decision during the once the trial has already get off the ground, because the phase 2 portion will probably easily take 6 to 9 months for you to enroll. And during that period of time, you probably have already collected additional data from your phase 1 dose escalation. You've also probably have more information from your competitors, etc. And at that time, you can entertain the idea as to what to do with this study. So I'm very pragmatic, by the way. And last but not least, I also want to mention that inclusion of control arm in a hybrid design shortens the timeline for registration, as opposed to the kind of conventional approach of conducting a phase 2 dose ranging study without control, followed with a separate phase 3, because you kind of the time, you kind of upfront your overall survival data from the get-go, and the time when you start your phase 2, essentially you are already in phase 3, as opposed to the sequential approach, like it's going to easily take another year for you to get into the door of phase 3. And remember, even if the phase 1, even if the stage 1 patients are excluded in phase 3 analysis, the data provides strong support for expedited approval of phase 3 and may be used to modify the phase 3 design. So, for example, if you have decided to take an operational phase 2/3 approach due to various reasons, for example, you want to have full access to those randomization data. In that case, your phase 3 will have to defend itself, but your phase 2 data, given that it has longer follow-up time, it can help you make when it comes down to accelerated approval. For example, by the time when you have finished accrual of phase 3 study and you want to ask FDA to give you accelerated approval, typically FDA may ask you to go away because you don't have longer survival data for these phase 3 patients, but now you have phase 2 randomized control data, which has a much longer follow-up time. So this is a list of the reference, and with this, I can entertain any questions you have.
Thank you, Kong, for a very interesting presentation on a topic that is so relevant for our later stage planning, especially when we're trying to deal with what doses to be used. I think we should go to the comment by Ryan. This is interesting method. It is likely to treat previous stage phase 1 as external and then borrow information from previous stage based on the similarity, which is quantified by C. Can you comment on that statement, or does the person who made the statement want to add additional perspective?
Right. It's analogous to our common statistical practice. Like, when you see basically, when you have two data sources and that generates two treatment effects, and in our practice, we may simply we may decide to pool data if there's not much difference. And on the other hand, if there is, we just use one over the other. So it's this kind of general concept of pool, if consistent, is a very kind of intuitive concept that's being applied throughout every aspect of clinical trial design or scientific research. That's another reason why I believe this is it's easier for clinician to understand. The combination test, I like it. It has been out there for many years. But if we ask a clinician with if you try to explain to clinician, it's hard for them to understand. And if you further tell them, by the way, I'm assuming that the dose will pick the winning dose will be picked with absolute certainty. That's the underlying assumption under my conventional combination test. I'm sure they will be very upset. There's just no crystal ball during dose escalation that the dose you are going to pick is definitely going to be the winner. And a lot of non-statisticians, they kind of ignore that because the method itself is already just like a black box to them. But I did have this similar discussion with some more savvy non-statisticians. Once they realize this is a is there underlying assumption that doesn't make any sense there. They were just so upset actually. But anyway, to getting back to the original question, yes, it has a lot of similarities with our common practice, whether it's in the Bayesian time framework, Bayesian framework, or on meta-analysis, or in any kind of data analysis.
So, thank you. Just received a comment. If it's operational, seamless phase 2-3, can you comment on the reasons for study team to be kept from the dose selection process based on page 2?
Page 2, okay.
Phase 2,
Oh,
sorry.
phase 2, okay.
Phase 2.
Yeah.
I
Well,
should have.
yeah. So it's just to kind of add some rigor to that. And personally, I'm not a strong advocate for this. Survival trial is survival trial. 20 years ago, when we do a survival trial, it's all open label. As long as all the patients' survival data, survival follow-up is complete and unbiased, that's something we will check at the back end, of course. There's just no way that a physician can kind of alter patients' survival or have any motivation to alter that in some way, and so that the so-called statistical integrity will be compromised. But nowadays, of course, we try to be as rigorous as possible. That's why to make regulatory agencies happier, the dose selection may be kind of insulated from the study team. You can either use a DMC to do that, or use a separate team for your own organization who are otherwise detached from the daily monitoring team to just again add some rigor.
Other remarks? Any questions? Remarks from the audience? Hui has her.
Yeah. Can you hear me?
Yes.
Yes. Thank you, Chen, for the next presentation. I have a question for the hybrid method where you use data-driven decision-making whether to or not to include the stage 1 data into the pooled analysis. Yeah, this exercise, so last slides, slides 10. I suppose when you are this exercise, you assume you know the underlying hazard ratio, right? And then you can say you can calculate the cutoff log hazard ratio. I wonder if you could share your thoughts in a real study setting where we don't know the real underneath hazard ratio. How do you choose the cutoff?
Right. Again, as I emphasized from the very beginning, the primary focus of this presentation is probably W, which I really have a issue about. And the secondary is C. And the reason why I include C is because it gives you some flexibility in your statistical design. It also gives you some flexibility from kind of high-level operational standpoint of view. Of course, the fact that W can now change from 0 to 1 gives as kind of extra incentive to potentially include a C before you pull the data, especially. Again, I have to emphasize, especially when you suspect that the stage 1 patients may give you a less treatment effect as compared to stage 2 patients. For example, you allow patients to cross over, and in a survival trial, that patient's survival can be long, and the crossover effect, it's going to disproportionately affect stage 1 and stage 2 patients, and if that's a concern, on top of the fact that you are also concerned about you have about random low, then you may want to consider. But I'm not suggesting you always have to. So that's kind of my response. Of course, you don't know, and most likely your clinical colleagues probably do not want you to use a C as a cutoff to exclude phase 1 stage 1 patients. But having said that, there is another scenario. I think it's hidden here. When in the base case that because of the enrollment pause, FDA has some kind of unspoken rule. If you have paused your study for over 6 months, they may not allow you to include stage 1 patients, or for whatever reason that the dose selection is partially unblinded, and so that FDA starts to question the integrity of the trial conduct. You may ask for you may suggest that, well, what if that we add a consistency check that allows us to include stage 1 patients, because otherwise whether you can include or not is at a regulatory agency's mercy. So in that case, at least this kind of consideration gives you opportunity to potentially include stage 1 patients. Of course, if they still don't want to include, you just don't have any choice. In that case, you just use stage 1 patients to strengthen your filing package. As I mentioned earlier, you may use that for helping with accelerated approval, or just or helping with the
check.
Design of the trial of phase 3. For example, you can use to change the sample size, etc., because the stage 1 data is your full
Kong?
Yes. Do you hear me?
I can hear him.
Now I do.
Okay.
Yeah, thank you for sharing your thoughts. So are you thinking actually the like how you in the ideal case
now I'm not hearing again.
You would choose C before the study plan.
John,
before the study
don't worry.
starts.
John, we can hear each other. It's just you we cannot hear. Don't worry. So for C, just like what I'm saying in the second bullet point, you don't need to specify a C. You can just start a randomized control phase 2. And in this process, you have enough time to entertain the idea of whether to make it operational study or inferential study, or for this matter, to let the data decide whether you want to which way you want to go. So in other words, you can apply hybrid design. So it's the C only gives you flexibility. It's not anything that you have to decide upfront. But of course, if you have enough data, etc., to decide, for example, you are very concerned that the stage 1 patients will likely have less effect for whatever reason. You don't necessarily need to reveal to FDA, of course. You can pre-specify, and this protects you from getting a lower treatment effect. In particular, if you are competing with another drug, and there are many reasons that this can happen. For example, let's just again totally hypothetical. You are developing a drug that works better in ex-US patients than in US patients. You started your sites usually in US or EU, etc. And for ex-US, it can sometimes takes longer time to get regulatory approval. Now you may be a little concerned. Well, if that drug indeed works better, there are such, VEGF inhibitor, for example, and there are a lot of other drugs. And the opposite can, of course, true, right? You want to protect yourself from getting a lower treatment effect than observed in stage 2. You can specify. It's just option. It doesn't mean that you have to consider, but the very fact that you can incorporate very explicitly into this hybrid design framework, is just a nice thing to have, because otherwise in the combination test field, you don't have such an option.
Yeah, thank you so much for sharing your experience. So just curious, have you had any success when you try to use this C cutoff to convince the regulatory agency to include your randomized phase 2 data into the pooled analysis?
No, we haven't gone that far yet.
Okay.
But to me, again, that goes to this comment, which seems to be a little philosophical. FDA has never said that you cannot do anything like this. Anything that's not specifically stated, that's not permitted in any guidance can be considered. You can run simulation or whatever to demonstrate that your type 1 rate is controlled. So in that regard, we on one hand, we haven't had such experience yet, but on the other hand, I don't see why they have any resistance. If they do, as I mentioned, we don't have to agree with them upfront. I know a lot of companies may not be willing to take this step. Let me just show you an example. I assume that you have been working in oncology for some time, and in oncology phase 3, FDA always wants you to have a O'Brien-Fleming alpha spending function, right? They often, if you ask for something else, they may just push back. But and I know a lot of companies just follow that. But if you take a look at the Keynote 24, which is probably one of the most important studies for Keytruda, the alpha spending function is not O'Brien-Fleming. And if we had applied O'Brien-Fleming, the famous Keynote 24 study wouldn't be successful at the interim analysis that it was. You can take a look at this study. So, of course, if we apply different alpha spending function, we are supposed to take the risk. If we, in that particular case, we spend more alpha, 3 times more alpha as compared to O'Brien-Fleming at the interim analysis. And if we fail to demonstrate, then we will have less alpha at the end. But that's a risk we sponsors are willing to take. FDA should never be in a position to dictate. There is no where that states in any of their guidance that we must have to use O'Brien-Fleming, right? Why do we have to follow that? It's all at your own risk. Like in this case, nobody has said that we must use the conventional p-value combination test.
Okay.
Why do we have to? I mean, I know sometimes when you talk to the regulatory agencies want to be a little kind of conservative, but that has to be questioned. Question. I mean, is being conservative necessarily good? Is conservatism naturally puts them on the kind of moral high ground? Well, if you are talking about a drug that can potentially save patients' life, and they insist on you testing p-value against 1.64%. But any reasonable person would say, well, that's excessive because the underlying assumption is totally wrong. Instead, it should test against 2.0, which is already kind of conservative, if not at 2.5%. And if the p-value happens to fall in between, is rejection approval really that moral? And I sometimes feel upset about this when I talk to our FDA statisticians. They just our role is to provide scientific and objective assessment, in whether in terms of data analysis or design. It's not our job is not trying to be conservative. Where does this conservatism come from? I mean, it's weird. It's not written in any law or in anywhere. We want to be more objective. That's our goal.
Yeah, get it. Thank you.
Yeah, thank you. So this you get
Gonna go
my
to the
idea.
other than Mark. If you start just with phase 2 study, how do you later change it to seamless design? Via protocol amendment? Is it acceptable from regulatory perspective?
Yeah, you can change your protocol. I don't see any reason why you can't. And if you look at some companies' protocol posted in clinicaltrials.gov, they always changing the design, or in this case, adding sample size is not uncommon by any means. Speaking of Keytruda, which I have worked on for so much time, our first immense study has changed from a 20, 30 patient study to hundreds of patients. I mean, eventually it has multiple approvals, of course. And it's totally fine. You just want to do it, in a way that's acceptable to regulatory agency. For example, the changing of a design is before any formal analysis. You try to keep the study double-blind controlled as much as possible. You try to insulate your study team from access to any unblinded aggregate data. So it's a black box out there, and we change the design, not based on any inside information of ongoing trial. Why can we not change? So it's certainly doable.
So we are at the end of the hour. I have one question about the minimum effective dose. Doesn't this somehow get at trying to get at that minimum effective dose?
Well, in reality, whenever you choose to use two doses in a study, whether it's just a dose ranging study or adaptive phase 2/3 design, adaptive phase 2/3 design with dose selection, the doses are hard. You choose them only because you really don't have any idea which one is going to be any better. If you are quite sure that one is better than the other, you probably shouldn't choose them in the first place. Or for this matter, you could have pre-specified some kind of step-down approach. In this case, including two doses just to make FDA happy, but still you have already made your mind which dose you will carry forward, and for this, and you are trying to pre-specify in a statistical design. So I guess what I'm trying to say, those kind of minimal effective dose or not, this kind of a concept is of course relevant, but in practical terms, it's just that the doses we are going to, there will be two or even more doses that we are just not so sure which one indeed is going to have better efficacy at the end of the day. So in this regard, whether which one is minimally effective dose, or whether this concept, how much is this relevant to this is kind of unknown.
I really like that. You put in the step down, and then if you don't do the step down because of the data, as you say at the end, we planned for a step down, but we didn't incorporate it. Is that what I'm hearing you say?
Well, what I'm trying to say is that oftentimes you really don't know which dose is going to
Right,
really work better, and that's kind of the fundamental assumption before you engage into any such a design.
Okay, we're a little bit over, but that's okay with me. Any other remarks? Thank you for staying over. If not, Kong, thank you for a very stimulating topic and discussion, and everybody have a great weekend.
Thank you again.
Okay, cheers.
Bye.